Helicobacter pylori, commonly known as H. pylori, is a spiral-shaped gram-negative bacterium that mainly lives in the pyloric region of the stomach and infects more than half of the world's population. Earlier, peptic ulcer disease was mainly thought to result from stress and excess acid production. However, after the discovery of H. pylori, peptic ulcer disease is now recognized largely as an infectious disease in which eradication of the bacteria can actually cure the condition. Interestingly, although the stomach contains highly acidic gastric acid, this organism has the remarkable ability to survive and persist within the gastric mucosa for many years. Today, H. pylori is recognized as a major cause of chronic gastritis, peptic ulcer disease, gastric malt lymphoma, and even gastric cancer. In fact, the World Health Organization has classified it as a carcinogenic organism because of its strong association with gastric malignancy. The infection spreads mainly through oral to oral and fecal-oral transmission, especially in areas with poor hygiene and low socioeconomic conditions. Moreover, increasing antibiotic resistance has made treatment more challenging in recent years. Interestingly, the infection is usually acquired during childhood and can persist lifelong if not treated. Therefore, understanding the pathogenesis, clinical manifestations, diagnosis, complications, and treatment of H. pylori infection has become extremely important in modern medicine. Now, to understand the pathogenesis of H. pylori infection, we first need to understand the basic mechanism by which this bacterium survives and damages the stomach. For H. pylori to establish infection, the bacteria must first enter the stomach and then successfully attach to the gastric epithelial cells lining the stomach mucosa. However, before attachment can occur, the bacteria first need to survive the highly acidic gastric environment and cross several protective barriers present inside the stomach. Once the bacteria are ingested, they eventually reach the stomach. Now, anatomically, if we move from the stomach lumen toward the stomach wall, the first area is the gastric lumen, which contains highly acidic gastric juice composed mainly of hydrochloric acid and digestive enzymes. Just beneath this lumen lies the mucus layer, which acts as a protective barrier against acid injury. Furthermore, this mucus layer consists of an outer loose mucus layer and an inner mucus gel layer. The inner mucus gel layer lies directly over the gastric epithelium, particularly over the surface mucus cells and gastric pits. This mucus layer protects the gastric epithelium from the damaging effects of hydrochloric acid and digestive enzymes like pepsin. Therefore, for H. pylori to successfully colonize the stomach, the bacteria must first survive the acidic gastric lumen and then cross these protective mucus barriers in order to finally reach and attach to the gastric epithelial cells. After entering the stomach, the bacteria first need to survive the highly acidic gastric lumen and then penetrate into the mucus layer. For this initial step, the bacteria possess two powerful survival mechanisms: urease production and strong flagellar motility. H. pylori produces the enzyme urease, which breaks down urea into ammonia and carbon dioxide. Consequently, the ammonia neutralizes the surrounding gastric acid and creates a more favorable microenvironment around the bacteria, thereby helping it survive within the acidic stomach. At the same time, bacterial motility also plays a major role in colonization. The flagella of H. pylori are specially adapted for movement within the gastric mucus layer, allowing the bacteria to swim through the mucus and reach the inner mucus gel layer near the gastric epithelium. Once the bacteria reach this area, they attach firmly to gastric epithelial cells using several adhesins. The best known adhesin is BAB-A, an outer membrane protein that binds specifically to Lewis B blood group antigens present on gastric epithelial cells. Lewis B blood group antigens are special carbohydrate molecules present on the surface of many cells in the body, especially on gastric epithelial cells, and also in body secretions like saliva and mucus. Now, the important point is that the pH of this area is relatively higher compared to the stomach lumen. Normally, the stomach lumen contains highly acidic gastric acid with a pH around 1 to 2. However, the surface mucous epithelial cells continuously secrete bicarbonate ions into the inner mucus layer. Consequently, these bicarbonate ions neutralize nearby hydrogen ions and create a protective microenvironment just above the epithelial surface. Because of this mucus bicarbonate barrier, the pH near the gastric epithelium and gastric pits becomes much less acidic, usually around pH 6 to 7. This protective mucus bicarbonate barrier is important because it prevents acid from damaging the stomach lining. At the same time, H. pylori takes advantage of this relatively safer zone and lodges within this inner mucus layer just above the gastric epithelial cells. This is the reason the bacteria are able to survive inside the stomach and attach firmly to the gastric epithelium and successfully colonize the stomach despite the highly acidic surroundings of the stomach lumen. Once H. pylori becomes attached to the gastric epithelium, it starts producing several enzymes and virulence factors that help it survive and damage the gastric mucosa. H. pylori produces protease and lipase enzymes which damage the protective mucus barrier of the stomach. As a result, the mucus layer becomes thinner and weaker, allowing hydrogen ions and gastric acid to diffuse more easily toward the gastric epithelium. Consequently, this increases mucosal injury and inflammation. Furthermore, H. pylori starts producing important toxins that contribute to mucosal injury and persistent infection. One major toxin is VacA, a vacuolating cytotoxin secreted by most strains of H. pylori. This toxin inserts itself into the membrane of gastric epithelial cells and forms tiny pores or channels in the cell membrane. As a result, important substances such as bicarbonate and other cellular contents leak out of the cell, which may help provide nutrients and a favorable environment for the bacteria. In addition, VacA also damages the mitochondrial membrane, leading to the release of cytochrome C from the mitochondria into the cytoplasm. Consequently, this activates programmed cell death or apoptosis, which ultimately leads to gastric epithelial cell death. Along with VacA, another important virulence factor produced by H. pylori is CagA, which is considered an oncoprotein because it is strongly associated with the development of gastric cancer. Once H. pylori attaches to the gastric epithelium, it injects CagA directly into gastric epithelial cells. Once inside the host cell, CagA undergoes phosphorylation and interacts with cellular proteins such as SHP2 tyrosine phosphatase. Consequently, this produces growth factor-like effects within the epithelial cells and stimulates cytokine production, leading to inflammation, abnormal cellular signaling, increased cell proliferation, and progressive mucosal damage. Over time, persistent inflammation and epithelial injury caused by these virulence factors contribute to chronic gastritis, peptic ulcer disease, precancerous lesions, and eventually even gastric cancer. Now, once H. pylori attaches to the gastric epithelial cells, it triggers a strong host immune response and causes chronic gastric inflammation. Initially, H. pylori infection triggers a local inflammatory response in which inflammatory cells such as neutrophils, macrophages, T lymphocytes, B lymphocytes, and plasma cells are recruited to the site of infection. Subsequently, a stronger adaptive immune response develops, including a predominant Th1 type cell-mediated immune response, along with a humoral immune response, where B cells and plasma cells produce antibodies against H. pylori. The first response against H. pylori is local gastric inflammation. Once the bacteria attach to the gastric epithelium, inflammatory cells such as neutrophils, macrophages, T lymphocytes, B lymphocytes, and plasma cells are recruited to the site of infection. Consequently, these inflammatory cells start damaging the surrounding gastric mucosa, leading to chronic gastritis and epithelial injury. At the same time, the infected gastric mucosa starts producing several inflammatory cytokines, including interleukin 1, 2, 6, 8, TNF-alpha, and interferon gamma. Among these, interleukin 8 plays a particularly important role because it strongly attracts and activates neutrophils, thereby amplifying inflammation at the site of infection. Now, after inflammatory cells reach the infected mucosa, the neutrophils recruited to the site of infection become activated and start releasing harmful substances known as reactive oxygen species and reactive nitrogen species. These substances are produced to kill bacteria. However, they also accidentally damage the surrounding gastric epithelial cells, thereby worsening mucosal injury and inflammation. Interestingly, although H. pylori mainly stays outside the cells, it still triggers a strong inflammatory immune response called the Th1 response. A Th1 type immune response is a type of immune reaction mainly driven by T helper 1 cells. Normally, Th1 responses are more useful against intracellular pathogens like viruses and some bacteria that live inside cells. However, interestingly, H. pylori is mainly an extracellular bacterium, yet it still induces a strong Th1 dominant response. Consequently, these Th1 cells produce inflammatory cytokines such as interleukin 2 and interferon gamma, which strongly activate macrophages and promote inflammation. Consequently, instead of effectively clearing the bacteria, this prolonged Th1-mediated inflammation continuously damages the gastric mucosa, leading to chronic gastritis, epithelial injury, ulcer formation, and even gastric cancer over time. Therefore, although the host immune response is initially activated to eliminate H. pylori, the bacteria are usually not completely eradicated. Moreover, in H. pylori infection, much of the gastric damage occurs not only because of the bacterial virulence factors themselves, but also because of the persistent host inflammatory and immune response against the organism. Now, the complications of H. pylori infection can vary greatly from person to person and mainly depends on both bacterial virulence factors and the host immune response. Most importantly, the pattern and distribution of gastritis largely determine the type of disease that eventually develops. When the infection predominantly involves the antrum of the stomach, it is more commonly associated with increased acid secretion. When the infection mainly involves the antrum, it increases gastrin release from the pyloric gland, and increased gastrin then stimulates parietal cells in the body of the stomach to produce more gastric acid. This mechanism was already discussed in detail in our proton pump inhibitor lecture. Therefore, although the infection is mainly located in the antrum, it indirectly causes increased acid secretion from parietal cells. So in this case, the patient presents with increased gastric acid secretion, which subsequently increases the risk of duodenal ulcer formation. In contrast, when H. pylori infection involves the body of the stomach or the entire stomach, the chronic inflammation starts damaging the parietal cells, which are the cells responsible for producing gastric acid. Over time, persistent inflammation leads to gastric atrophy, meaning gradual loss and destruction of these acid-secreting glands. Consequently, gastric acid secretion progressively decreases, and in this case, patients are more likely to develop gastric ulcers, gastric atrophy, intestinal metaplasia, and eventually even gastric carcinoma. Multiple studies have shown that patients infected with H. pylori have a significantly higher risk of developing gastric carcinoma compared to non-infected individuals. H. pylori infection is strongly associated with gastric mucosa-associated lymphoid tissue lymphoma, commonly known as gastric malt lymphoma. In fact, most patients with gastric malt lymphoma are infected with H. pylori. Interestingly, eradication of the bacteria alone can lead to regression of the lymphoma in many patients, although some resistant cases may progress to more aggressive tumors. The relationship between H. pylori and gastroesophageal reflux disease is still not fully understood. Some studies suggest that H. pylori may worsen stomach inflammation, while other studies suggest that it may actually reduce the risk of acid reflux disease in some patients. However, H. pylori infection can interfere with normal iron metabolism and eventually contribute to iron deficiency anemia. In addition, H. pylori infection can lead to chronic gastritis, peptic ulcer disease, hypochlorhydria, and atrophic gastritis. Consequently, reduced gastric acid secretion impairs iron absorption because gastric acid normally helps convert dietary iron into a more absorbable form. As a result, chronic infection may gradually lead to iron deficiency anemia. Furthermore, when H. pylori causes atrophic gastritis involving the body of the stomach, intrinsic factor secretion may also become impaired, as intrinsic factor is released by the parietal cells of the stomach, mainly located in the body and fundus of the stomach. At the same time, hypochlorhydria or achlorhydria may develop, further reducing the absorption of both iron and vitamin B12. Consequently, patients may develop not only iron deficiency anemia but also vitamin B12 deficiency over time. Now, diagnosis. H. pylori infection can be diagnosed by both non-invasive and invasive methods, and the choice of test mainly depends on the clinical condition of the patient. Non-invasive tests include the urea breath test, serological tests, and stool antigen tests. Among these, the urea breath test is one of the most commonly used and reliable tests. This test works on the principle that H. pylori produces large amounts of urease enzyme. During the test, the patient ingests urea labeled with carbon, and if H. pylori is present, its urease enzyme breaks down the urea into ammonia and carbon dioxide. Consequently, labeled carbon dioxide is detected in the patient's breath, indicating active infection. This test has very high sensitivity and specificity and is useful both for the initial diagnosis and for confirming eradication after treatment. However, after therapy, the test should be performed only after at least 4 weeks to avoid false negative results. Another commonly used non-invasive method is serological testing, which detects antibodies, especially IgG antibodies against H. pylori. This test is inexpensive and widely available, especially before treatment. However, since antibodies may remain positive even after the infection has been eradicated, serology is not very useful for confirming successful treatment. Furthermore, stool antigen tests are also highly useful because they directly detect H. pylori antigens in stool samples. These tests have high sensitivity and specificity and can also be used to confirm eradication after treatment, provided testing is done at least 8 weeks after therapy. Moreover, stool antigen tests perform well in children of all age groups and are considered one of the preferred non-invasive tests in pediatric patients. Now, in patients with alarming symptoms such as anemia, gastrointestinal bleeding, weight loss, or in patients older than 50 years, upper gastrointestinal endoscopy is usually recommended. During endoscopy, biopsy samples are taken from the gastric mucosa, especially from the antrum. The most commonly used biopsy-based test is the rapid urease test, which quickly detects urease activity in the biopsy specimen. This test is inexpensive, rapid, and highly accurate. However, false negative results can occur in patients who recently had gastrointestinal bleeding or those taking antibiotics or acid-suppressing medications. If the urease test is negative but suspicion remains high, biopsy specimens can also be sent for histopathological examination. In addition, culture of H. pylori with antibiotic sensitivity testing is usually not performed routinely for the initial diagnosis but becomes important when first-line and second-line eradication therapies fail, as it helps guide appropriate antibiotic treatment. Now, the main goal of treating H. pylori infection is not only to relieve symptoms such as abdominal pain and dyspepsia, but also to promote ulcer healing, prevent ulcer recurrence, and reduce long-term complications such as gastrointestinal bleeding, gastric cancer, and malt lymphoma. One of the most important discoveries in peptic ulcer disease was that eradication of H. pylori dramatically reduces ulcer recurrence rates. Therefore, most international guidelines recommend eradication therapy in patients with documented peptic ulcer disease, gastric malt lymphoma, unexplained iron deficiency anemia, idiopathic thrombocytopenic purpura, and in many patients with dyspepsia. Now, as shown in the attached table, multiple treatment regimens are available for H. pylori eradication. However, no single drug alone is effective. Consequently, combination therapy using multiple antibiotics along with acid suppression is required. Among these, clarithromycin-based triple therapy is one of the most commonly used first-line regimens. This regimen usually includes a proton pump inhibitor along with clarithromycin and either amoxicillin or metronidazole for about 14 days. The proton pump inhibitor reduces gastric acid secretion, thereby improving antibiotic activity and promoting ulcer healing. Another important regimen shown in the table is bismuth quadruple therapy, which combines a proton pump inhibitor with bismuth, tetracycline, and metronidazole. This regimen is especially useful in areas where clarithromycin resistance is high. In addition, other regimens such as concomitant therapy, sequential therapy, hybrid therapy, and levofloxacin-based regimens are also used depending on antibiotic resistance patterns, previous antibiotic exposure, patient tolerance, and local treatment guidelines. Studies have shown that 14-day treatment regimens generally provide better eradication rates compared to shorter 7 to 10-day regimens. Commonly used antibiotics include amoxicillin, clarithromycin, metronidazole, tetracycline, levofloxacin, and bismuth compounds. Although triple therapy is effective in treating H. pylori infection, it also has several important limitations. One major problem is poor patient compliance because patients need to take multiple medications for many days, and side effects are also common. Therefore, newer treatment regimens are being simplified so that medications can be taken only twice daily, thereby improving adherence. To improve convenience, some pre-packaged treatment kits are also available. For example, pre-pack contains lansoprazole, clarithromycin, and amoxicillin and is usually taken twice daily for 14 days. Another regimen, Helidac, contains bismuth subsalicylate, tetracycline, metronidazole, and proton pump inhibitor or H2 blocker, which are taken 4 times daily for at least 14 days. Now, if first-line triple therapy fails despite good patient compliance, the most likely cause is infection with a resistant bacterial strain. In such cases, salvage or second-line therapies are used. Common options include quadruple therapy, where clarithromycin is replaced with metronidazole or vice versa. Other second-line or alternative regimens include levofloxacin-based triple therapy, levofloxacin sequential therapy, hybrid therapy, concomitant therapy, and the load regimen, as shown in the attached table. However, if 2 treatment courses fail, culture and antibiotic sensitivity testing should ideally be performed, although these tests are technically difficult and not widely available.